Good morning. Good morning one and all. Today we will discuss about the recent advances in management of hepatitis B. Before going into the topic, we will just have a brief discussion about liver and its functions. As we all know, liver is the second largest organ of the human body. It weighs around 1.5 to 1.75 kgs. It will be interesting to note that liver performs more than 500 different functions in our human body. Some of the important functions are a synthetic function, detoxification and excretion, storage, production of bile salts, and hormonal inactivation. There are n number of ways by which liver can be injured, but the most important ways are by alcohol intake, viral infections like hepatitis B infection, hepatitis C infection, cholestasis, steatosis, that is accumulation of simple fat, drug abuse, autoimmunity. So what are the stages of liver damage? Liver can be damaged in these 4 stages. A person is having a healthy liver. When he sustains an injury in any form, be it alcohol or viral infections or drugs, he goes in for fatty liver. That is deposition of fat in the hepatocyte. If there is more than 10% of hepatocytes are filled with fat, then we call it as fatty liver. Then he goes in for scar tissue formation, which is called as fibrosis. Next is growth of the connective tissues called cirrhosis. Out of all these 4 stages, the most important is fatty liver stage, because it gives us the golden opportunity to treat, and if we treat in correct time, it is 100% reversible. Now coming to the hepatitis B infection. Hepatitis B is 100 times more infectious than HIV. We all know about HIV, but hepatitis B is more dangerous. It is 100 times more infectious because it can live outside the human body for 7 days. And most of the people who have this infection, they will be clinically asymptomatic and they themselves won't be knowing that they have this infection. So early detection by blood test is the only way to detect and treat these patients. So what is the epidemiology? India falls here in the intermediate stage, that is 2 to 7%. Some countries which have more than 8% falls in high and less than 2% is low, and our country is in the intermediate category. We have a total of around 400 million people in the world living with hepatitis B, and 200 million people living with hepatitis C, and 200 million people living with other hepatitis viruses like hepatitis A and hepatitis E. In India, we have 60 million people living with hepatitis B and 20 million people living with hepatitis C. So such a huge population of patients are there with these viral infections. Who is he? Any guesses? So he is the person who discovered this hepatitis B virus. And he not only discovered this B virus, he also invented the test kit in 1964, and he also developed the first hepatitis B vaccine. He is Dr. Blumberg. For his work in hepatitis B infection, he received the Nobel Prize in 1974. So such a great personality. And every year on his birthday, in July 28, we celebrate the World Hepatitis Day. The theme for the World Hepatitis Day 2024 is it's time for action. Why? Because out of the 600 million people living with hepatitis infections, we have diagnosed only less than 20%. Out of the 20%, we have treated only less than 5%. So a huge population is present without detecting, without getting treatment. So it's time for action to go on screen and treat these patients. Something about the virus. Hepatitis B virus belongs to the Hepatidinaviridae family. Here we can see the outer shell, it's a double-shelled particle, and inner we have the genetic material, the DNA material. So this is the electron microscope picture where you can see the pictorial representation where you can see the HBsAg and the core antigen. Inside we have the DNA polymerase. So routes of transmission, it can be spread by blood transfusion, organ transplantation, unprotected sexual contact with hepatitis B positive person, contact with infected fluids, sharing of razors and needles, and most important is vertical transmission from the mother to the child. Whom should be screened? Any person who has abnormal LFT, liver function test, be it be anything, be it be bilirubin or albumin, globulin, PT-INR. If it is abnormal, then we have to go and check for hepatitis B and hepatitis C. Next, household and sexual contacts of infected persons, they are prone to get infected. Pregnant women, HIV positive patients, hemodialysis patients, IV drug abusers, and finally, healthcare workers. So what are the symptoms and signs? We divide into two categories. One is the acute hepatitis and next will be the chronic hepatitis. Acute hepatitis, you have fever, malaise, nausea, vomiting, abdomen pain. Finally, it will be jaundice. And chronic, the person will develop cirrhosis and decompensation and liver cancer. What are the complications? The person may have acute liver failure, he may have cirrhosis, he may develop liver cancer, hepatocellular carcinoma. So what is the outcome? A person who has been infected, either he may become asymptomatic or symptomatic. If it is asymptomatic, he may develop resolution and immune, or he go in for chronicity with liver cancer and cirrhosis. If it is symptomatic, again he may get resolved, or he may go in for chronicity with cirrhosis and liver cancer. How to screen these patients? You can screen by a simple blood test by card method or ELISA method, HBsAg. If it is negative, then he is normal. If it is positive for more than 6 months, he has chronic hepatitis B. To check for the immunity, you do the anti-HBs. If it is more than 10, then the person is immune. If it is less than 10, he is not immune. So these are the other serological markers of the virus. HBs antigen, which indicates that the person has infection. Anti-HBc, it shows the person has a previous infection. IgM anti-HBc, which shows he has acute hepatitis. HBeAg shows acute active viral replication having high infectivity. And anti-HBs, which shows whether the person is immune or not. After doing the markers for the virus, what are the things which we can do for the patient? From the patient's liver point of view, we can do the LFT and look at his ALT. Then the fibrosis marker, non-invasive test like fibroscan or invasive liver biopsy. This is the fibroscan. A person is sending by the transducer ultrasonic waves inside the patient's liver, and these ultrasonic waves will be reflected back and the report will be like this. Someone who has a value of around 7 to 7.5, he has good liver. If it is more than 7.5, then he has bad liver. You have to go and intervene and treat these patients. So how to proceed with a person who has HBsAg positive? If a person is HBsAg positive, you go and do all those tests like HBeAg, HBV DNA and LFT and fibroscan. If a person has elevated ALT or high number of virus, you go and treat the person. Or if the person has a family history of liver cancer, or if he has extrahepatic manifestations, you go and start on antivirals. This is from the European Society. There are a lot of societies which gives us the definition and the algorithm how to treat. One is the European Society, another one is American Society, and then we have our own INASL. This is what we usually follow, the European Association for Study of Liver Disease. You categorize HBsAg positive patient into two categories, HBeAg positive and HBeAg negative. Then you find out whether the person has chronic infection or chronic hepatitis. The thing is that anyone who has infection, you need not treat the person. Only when the patient develops inflammation and fibrosis, you have to go and treat. That means a person has infection but he has good liver, you need not treat that person. You have to just observe the patient. follow up the patient. A person who has infection, he has a bad liver in the form of elevated ALT or fibrosis or cirrhosis, you have to go and treat. In this tabular column, you can see the person who has chronic infection, HBeAg positive chronic infection, he has high DNA, HBV DNA, more than 7, but ALT is normal, liver is normal. You just follow up the patient. Whereas in the second category, hepatitis category, the DNA is bit less, 10 to the power of 4 to 10 to the power of 7, but the liver is damaged. The ALT is elevated, more than 2 times the upper limit of normal, which is like more than 80. And the liver, there is fibrosis, moderate to severe fibrosis. You go and treat this person. The same is for the next HBeAg, which has a mutant. If here the DNA is also low, less than 2000, and ALT is normal, liver is normal, just observe the person. In chronic hepatitis, the virus is more than 2000, the ALT is elevated. He has inflammation, fibrosis, you go and treat the person. This is how we have to look at the treatment part of hepatitis B. The basic idea is, if a person has good liver, you just observe the person. If a person has bad liver like fibrosis or inflammation, you go and treat the person. So, in immune tolerance, you wait and observe. In immune clearance, where the ALT is more, treat. If it is immune control, you just observe. If it is immune escape, then you have to go and treat. What are the goals? You have to reduce the DNA levels to less than 10 to the power of 5. Normalize the ALT. And last is to reduce the risk of developing cirrhosis and liver cancer. So these are the societies which give us the guidelines. These are same things which we have seen in different format. If a person has HBsAg E positive, if it is more than 20,000, if the ALT is also more, you go and treat. If it is less, you have to just observe them. Same for HBeAg negativity. These are the European Society guidelines, which shows same things. So what are the drugs after knowing about the algorithm and other things? What are the drugs we have? We have injectables like interferons, then lamivudine, telmivudine, entecavir, tenofovir, adifovir, out of which now the interferons are outdated because it has lot of complications. We have to use either tenofovir or entecavir. Entecavir comes in 2 doses, 0.5 milligram and 1 milligram, and tenofovir disoproxil fumarate is around 300 milligrams, and tenofovir alafenamide is 25 milligrams. Out of all these drugs, these are the drugs which you usually use: entecavir, tenofovir disoproxil fumarate, and tenofovir alafenamide. How to choose entecavir or tenofovir alafenamide or tenofovir? If a person is more than 60, or if a person has bone disease like osteoporosis, if he has renal issues, if he has CKD, you go and use entecavir because tenofovir has bone and renal toxicity. How to follow up the patient? Now we have known how to screen a person, how to evaluate a person, and what to treat. How to follow up him? Do an LFT every 3 months, HBV DNA every 6 months, ultrasound abdomen every 6 months to look whether the person is developing liver cancer, HCC or not, and HBeAg every yearly. So these are the endpoints where suppression of HBV DNA, ALT normalization, and HBsAg loss, which is very rare. This is about a word about pregnancy and hepatitis. All pregnant women should be screened. If the level of DNA in a pregnant woman is more, if it is more than 2 lakhs, you have to start treatment with tenofovir at 24 to 28 weeks of gestation. And breastfeeding is not contraindicated. We have a national program also because we have so many patients with hepatitis B. We have a national program, National Viral Hepatitis Control Program, in which we screen these patients and treat these patients, follow up the patients free of cost. This is a simple recap. Mr. P, 62-year male, he is detected to have HBsAg during evaluation for an elective minor surgery. Patient is asymptomatic, he is not an alcoholic, not a smoker, but he has comorbidities. He has diabetes for 7 years on treatment. Family history of liver cancer is there. Investigations, LFT, in LFT ALT shows 64. international units, and HBeAg is negative, HBV-DNA is high, more than 2000, and liver stiffness measurement is more, it is more than 7, 12. What is the diagnosis and management? The diagnosis is HBeAg negative hepatitis, and we have to treat with either entecavir or tenofovir. But the age is more for this person, 62. So we prefer to use entecavir 0.5 milligram OD. Thank you.
With the knowledge of the legacy of hepatitis B from discovery to defense. Your clear insights about the advancements in hepatitis B management has created a moment of epiphany, leaving us informed and inspired. Your expertise is invaluable. Thank you for sharing it with us.
We now invite the chairperson, Dr. B. Balachandra sir, to do the honors.
Doubts?
It gives us a great pleasure to invite our chairperson, Dr. Arunjyoti sir, to share your thoughts and opinions about the session.
Thank you, sir. Thank you for the great presentation. Sir, is there any role of dual drugs like tenofovir and entecavir? If there is a tenofovir resistance?
No, the drugs, entecavir and tenofovir, they don't have any resistance. But the role is not also much using entecavir or tenofovir, combining entecavir or tenofovir, there's no much use.
Recently, we had a patient whose bilirubin is around 50, and we have started him on tenofovir. Still, his liver levels are a bit elevated. So when can we expect the LFT values to normalize?
Total bilirubin is 15. Still. Thing is that we start these antivirals to reduce the viral load and also to reduce the inflammation. But there is something which is called as lag bilirubin, because some amount of bilirubin will be attached to the plasma proteins like albumin. The thing is that we have to take care of only the ALT, which gives a correct picture. So only you have to guide with the ALT, not with bilirubin. Bilirubin will take its own time to resolve, because that's a lag bilirubin. So we have to go with the ALT levels. Whether ALT is reduced or AST is reduced, then we should be happy.
Thank you.
Thank you.
Sir, not two questions.
Yes, sir.
If a person is taken hepatitis B vaccination,
Yes, sir.
how long he has to wait before giving blood donation?
By 6 months he has to wait, sir.
No, there is a lot of studies shows maximum 21 days. Is there any guidelines?
For blood donation.
Which guidelines says 6 months? Because 6 months is a very huge time. Because
The completion of the vaccine schedule itself is 6 months, sir. You have to 0, 1 and 6.
0, 1, then it will take a 5 months gap.
He has to wait till that for the third dose completion.
Now, is there any specific guideline, WHO guidelines or your government of the...
No, actually...
guidelines? Because if you go to Google, it says 21 days.
Okay, sir.
Because so many millions of people are taking hepatitis B, then you are denying.
Yeah, they can donate. There's no issue in donating, because if the person is not having HBsAg, then it's well and good. The virus is not going to spread. The vaccine is for his own protection. The vaccine is not for the donation and other things.
Whether he can donate blood or not, that's one. If I take hepatitis B vaccine today, should I wait or even tomorrow I can give blood donation? No problem.
No, sir, it's better.
Whether it will show hepatitis B is positive if they screen my blood.
No. If you do the vaccination, it's for only the antibody production. So HBsAg is a virus. It is not going to enter the person's body. So
you can give blood.
he can give blood. That's not an issue.
So another thing is, suppose when young fellow is hepatitis B positive, some screening done, whether he can marry normally or he has to disclose it before marriage. I am hepatitis B positive, because it can transmit to the fetus, then vertical transmission, so many things. He may die also sometimes, hepatitis cirrhosis or
that is there.
carcinoma. So there is a risk. Should I tell? Is there any guidelines on that?
That is up to the person. But if you tell all these things, whether marriage will be...
Suppose somebody is positive, how do I know he got it from sexual transmission or some other transmission?
Actually, what the guideline says, we should not discriminate these patients. HBsAg positive patients, we should not discriminate. Because the thing is that the problem risk is that he may transmit the infection to his wife or the husband. So the other person should get vaccinated. So that is the thing. He should go and advise them to get vaccinated. And after vaccination, they should take all the 3 doses. If they are still worried, they can do the anti-HBS. If it is more than 10, then nothing. Then they can be happy. But thing is, it will take about 6 months' time for the vaccination, for the antibody production. They have to wait. So it's like a social issue. After knowing all these things, we can say it's okay. But without knowing all those things, it will be a bit. The other person may feel a bit alarmed about the virus and other things.
Sir, what if a surgeon gets the HPS-AG positive?
Sir?
If a surgeon gets the HPS-AG positive, will he continue to do the surgery or if another healthcare worker also, whether they will be permitted to do the
If a healthcare worker is positive, they have to be allowed to do everything. Only thing, once they do an invasive procedure, their HPV DNA should be less than 1000. They should do the HPV DNA. If it is more, then high chance that he will transmit the virus. Then they should take the tenofovir or anti-caver and they should suppress their viral load to less than 1000. If it is less than 1000, we can allow them to do surgery, hemodialysis, invasive procedures, everything.
Another thing is, we all healthcare providers, doctors, we all taken 3 doses. How do I know I am protected? So, should I screen for antibodies?
Actually, it is not necessary because once we complete the 3 doses, the 3rd dose is a booster dose which increases our anti-HBS level. If still we have doubt, we can do the anti-HBS. If it is more than 100, then we are happy. If it is more than 100, then we are very well immune to the virus.
Thing is, they say in adult if you are vaccinated, immunoconversion is very low, not like children. That's why I am asking. That's it.
That's it. We have to do the anti-HBS level. If it is less than 10, then we have to go for the second shot also. Some person will have resistance also, vaccine resistance. So they should again repeat 3 doses until it becomes more than 10. Thank you, sir.
Thank you to our chairperson for sharing your thoughts and to our
We now invite the chairperson, Dr. B.V. Balachandra sir, to do the honor and expressing our heartfelt appreciation for the valuable session of Dr. P. Sivaramakrishnan sir.
and Dr. Arunai sir for their generous contribution to this session.